Good evening, everyone. On behalf of Young ENT, it is my privilege to welcome you all, the delegates, to today's academic webinar on CSF Rhinorrhea. At the outset, I would like to thank and express our sincere gratitude to the visionary founding members of the IOHNS, whose dedication laid this Young IOHNS association. We also extend our heartfelt appreciation to the senior mentors and executive committee members of IOHNS for their unwavering guidance and encouragement. Now, it is my privilege to welcome our moderator for today's session, Dr. Gautam Khaund, sir. Sir is one of the most respected names in the field of Indian otorhinolaryngology. He serves as the Chief ENT Consultant at Nightingale Hospital, Guwahati. He is the Head of Department at ENT at Pratiksha Hospital, Guwahati. He is also a visiting consultant at Apollo International Hospital, Guwahati. He is a distinguished leader in our specialty. He has been the president of IOHNS. He is currently serving as the vice president of APSI, the Phonosurgery Association. Beyond his clinical and organizing leadership, he is also a member of board of director of Pratidhwani Center for Child and Speech Hearing. Dr. Khaund has made significant academic contributions, having authored multiple chapters on pediatric airway and cochlear implant surgeries. Sir is truly a person who's given us a lot as a teacher and mentor, and he's someone who will grow through the next generation of ENT as a legend. Sir, it is truly a privilege to have you with us in this evening. We are grateful that you have agreed to moderate this session on a short notice. We are certain that your vast experience and insight will enrich today's session, sir. Over to you, sir.
Thank you very much.
Ma'am, I wanted to share, 1 second, I'll just put a...
Yeah. Thank you very much for your kind words. The Young Indian Academy has been doing a very great job of organizing this webinar series, and you have all been very enthusiastic, and you have been taking the organization forward. We hope to see more of your activities in the future. We are going to see activities in the IFOS this year from the young group of the Indian Academy. So with these words, I would like to introduce our speaker for today, Dr. Hetal Marfatia Patel, and she is a professor and head of the... You could share her CV on the screen. Dr. Hetal Marfatia Patel is a professor and head of the department at the prestigious Seth GS Medical College and KEM Hospital, Mumbai. She has done a training at KEM and has done fellowship in endoscopic sinus surgery at Graz, Austria, skull-based fellowship at Pittsburgh and University of Pennsylvania, and otology fellowship at France, cochlear implant and BAHA training from Australia, and laryngology fellowship at Harvard. She is the recipient of the prestigious EMARC, RF Cooper, and the Cochlear Implant Group of India, that is a CIGE award. She has numerous publications in various international and national journals, and she is invited as a faculty all over the country and abroad for training in otology, FES, and cochlear implant. She is a versatile surgeon, and she is adept at endoscopic sinus surgery, cochlear implants, microlaryngeal surgery, and her recent passion, as you know, is BAHA. She has started a club for patients with microtia and venotia under the name Here for All at KEM Hospital, Mumbai. She is running the largest cochlear implant program in the civic hospital. With these words, I welcome Dr. Hetal to start her presentation, and we look forward to have an enriching session of learning. Thank you very much.
Good evening,
Hello.
everybody.
Yeah.
It's proud privilege to share the podium with all of you and share my knowledge with the young ENT surgeons. And this is an excellent program, and that too on a Sunday evening, where the residents are relatively free and they can really take most advantage out of this. So without much ado, I'll start with my topic. Today's discussion is on CSF Rhinorrhea. Somebody has stopped sharing my screen. So this is KEM Hospital, and this has got me vast opportunity to share different kind of patients. And in today's collection of cases, you will really see that what an experience this hospital has given to all of us. Whenever you think about the CSF leak, you think about the CSF leak is coming from the anterior cranial fossa. Whenever you think that most of the time the CSF leak occurs from the anterior cranial fossa, but there are times when you will have leak coming from the middle cranial fossa and as well as it's coming from the ear. So one must keep that at the back of the mind that there could be CSF leak coming from the sides other than anterior cranial fossa. So what we are going to discuss is how we are going to fix the CSF leak and what are the ways to close this CSF leak, because there are various ways of skinning a cat. The way, depending upon the size, site, and extent of the defect, you have various techniques to close these leaks. And it is easy to close this leak. The whole history goes way back in 90s, early 90s. When we wanted to start this work endoscopically, we had to call our neurosurgeon down. He was very generous. He came down to ENT/OT and we could demonstrate him how we could do extracranial repair of the CSF leaks. And once he saw this surgery, he felt that this is far delicate way and non-invasive way to close the leak. And then he started sending us a lot of cases to do this repair. So KM being the mecca of doing the CSF leak closure, probably we have highest number of CSF leak closure done in the country. And when we presented our work at Indian Academy, American Academy, they were not ready to believe the numbers. And it was very important for us to show them the picture of railway station of Churchgate at 6:30 p.m. and showed that how many number of people travel every day and there are so many road traffic accidents that it is possible to have this kind of data. And that is what some of the important cases and interesting cases I would share with you guys today. We know that the commonest indication where we get the CSF leak is a injury to head. The head trauma can be of various kinds. So you know that a CSF leak can be traumatic. Not that all traumatic CSF leak requires surgical intervention. You can always give them a medical management and conservative line of treatment, but only those who present with a large defect with associated pneumocranium or those presenting with intermittent CSF leaks requires immediate surgery. The crux of treating the CSF leaks is that you must localize the site of CSF leak properly. And you must keep at the back of your mind that there are series of patients who do not give you history of trauma and they lie under the bracket of spontaneous CSF leak. And it is usually seen into fat, fertile female of 40, almost a similar triad like cholecystectomy, that usually it is female patient. You don't have any history of trauma and they have spontaneous CSF leak. With the increase in the amount of obesity, we are seeing now the spontaneous leak in early age group of 20-25 years also. And it is also associated with so-called vitamin D deficiency. But if you screen the entire population of India, you will get 80% of the patient with vitamin D deficiency. So how much to believe in that is questionable, but we always do vitamin D level, calcium level for all these patients and do give them the replacement also. So one of the important aspect of treating these cases properly is to identify and delineate the exact site of CSF leak, and for which you have to have an excellent radiological colleagues who can help you look at it, and you have to go to console or see the DICOM images and learn the every millimeter of the scans. One of the gold standard in diagnosing the site of CSF leak is CT cysternography. That means through the CSF cistern, the dye is injected and patient is kept in the head-low position, and then the screening is done. So, but in the patients who are not able to who are not able to use this dye, like those patients who have allergy to the dye, or those who are just recovering from the meningitis, where you would not like to inject the dye, then in those patients you could do HRCT of PNS with MRI of PNS, and then you can superimpose the findings from both and identify where the site of leak is. However, still, when you are in doubt, CT cysternography remains the gold standard for diagnosing this site of leak. So what one does is HRCT of PNS, and you can combine that with T2 weighted MRI. As you can see here that there is a small defect in the left side of the roof of ethmoid at the junction of lateral lamella and the fovea, and same site is having leak coming from the on the MRI. You can see in MRI, T2 weighted MRI, you see the CSF as brilliantly white secretions. In addition, what we try and do is put a patty in the nasal cavity, and this patty in the nasal cavity can pick up the dye, and you can screen that. And sometimes you feel that there is bilateral leak, but when you put a patty and it doesn't get soaked, that means it is a unilateral leak which is trickling onto the other side. So it is very important to put that little patty in the nostril when you are doing a CT cysternography. If you do a CT-PNS and don't find the site of the leak, don't stop there. Extend your study to HRCT temporal bone. And in the HRCT temporal bone, look at the pneumatization. You look at if there is any defect in the tegmen, and also look at if there is any associated anomalous cochlear vestibular system. In fact, last week we had a patient who had been operated intranasally for a CSF leak closure, and that patient had bilateral abnormal cochlea and the leak coming from both the ears through the intact tympanic membrane to the eustachian tube, which presented as a CSF Rhinorrhea, but it was actually coming from the ears. You can also do MRI with gadolinium, where you can see beautiful eustachian tube sign. Once we come to those cases, I will show you how that looks. Coming to the first case, where the patient presents to you with a nasal mass. It's usually a meningocele, but any nasal mass in a pediatric age group, do not take a biopsy. Always look at the CT scan, find there is associated site of defect or not, and rule out that there is no meningocele. Here you can see there is a defect in the right side of cribriform plate, and there is a huge encephalocele coming in the nasal cavity. Now in these cases, what we like to do is reduce this encephalocele, either with bipolar cautery or with debrider or with coagulation, and reduce this encephalocele. Once you have reduced, you go to the base of it, identify the site of leak, and repair that area. Depending upon the size of the defect, you will choose what material you will use, either fascia, fat, cartilage, muscle, whatever, or pedicle flap. This decision is taken on table depending upon the site and size of the defect. Coming to the same patient, you can see that the defect is medial to the middle turbinate. This is the right nostril. This is the encephalocele. And as it was shown in the animation, what we are trying to see is trying to reach at the root of the encephalocele. So here you can see the bipolar cautery coming in. I usually don't like to debride this encephaloceles because you see sometime a large vessel running through it and you can have a lot of bleeding. So I like to achieve my hemostasis. Either I use a bipolar cautery, or lately I've been using a lot of coagulator to do this same thing. You can see the encephalocele coming out. And here I'm creating a raw area. CSF leak is the only surgery where you would like to create raw area. Here you are seeing that the septal incision is taken and a small piece of cartilage is harvested because size of the leak is quite big in this little child. So here you are seeing that the cartilage is being used to reinforce the area of defect. If you see very carefully, you see crisscrossing on this cartilage. This is done so that I have little malleability of the cartilage, and to prevent the leak by the side of the cartilage, we put another layer of the fat and it is spread all around. And here you are seeing the Frankie, which I make it with the fascia. We like to use the fascia lata, and the center part of the fascia lata is used with gel foam or Surgicel, something like a kathi roll. And you unroll that, remove that piece of gel foam, and now once it is spread well, then you are putting, here you can see the tissue glue coming in. Now you cover the entire area with the gel foam and close this site of CSF leak and put piece of Merocel as a tampona. You can see this child post-operatively. When I called up that how is the child doing, this is the video which parents sent me. We have had patient where by the time we finish surgery, by evening, the patient pulled out the Merocel packing. So nowadays, we give them the boxer's dressing on the nose, on the hands, both the hands, so that they can't pull out the Merocel, because children are obligatory nose breather and they prefer to breathe from the nose. The moment you block their nostril, they have to mouth breathe, and which is a little difficult for them. So we have started using it, and lately we are using absorbable packs like wellness pack, so that you don't have to do any pack removals. You can also have a leak coming from the medial lamella. You can have a leak which can be diagnosed on diagnostic endoscopy once you decongest the area and use the the 30-degree telescope to identify. You can see a small arachnoid prolapse coming medial to the middle turbinate, and that is the leak coming from the medial lamella. And here is the leak which is coming from the lateral lamella. So if you study this scan, the medial lamella is intact, and the defect is where I've marked it red. That is the lateral lamella, and there is a tiny encephalocele coming out of the lateral lamella. Same surgery. Here already anti-ethmoectomy is being done. We are trying to locate the site of the leak, but before that, frontal ostium is opened up so that your repair does not block the frontal ostium. And here is a tiny arachnoid. This tiny arachnoid is being reduced using a bipolar cautery. Still, I have not reached at the root, but you can see the pulsation of the brain. And once you go and reduce it further, you are seeing the gusher. So you don't have to go to Belgium to see the peeing boy. You can see sometime in the ENT/OT. And if you pinch and if you close that area, the active CSF leak will close. Still, we have not reached the base of the defect. So go and try. Now you can see that bony defect as well as defect in the dura is seen very clearly. And you can see a strip of fascia being introduced through the defect very nicely. Lately, I use a lot of fascia in a form of strip, because you can under visions introduce, because blob of fat, when you try to put, sometime you are lost. So once that is put, I'm spreading the graft, keeping in mind that I don't have to cover the frontal ostium. And again, I'm putting the glue, and gel foam is being put all around. Coming to the sphenoid leak. So a lot of sphenoid leaks are spontaneous. And if you see and if you study the cases of spontaneous leak, you will find one thing in common, that there is an extensive pneumatization. And you can have in a pneumatized, that means the bony area is spread over a large surface area. So the bone is relatively thin. Now, constant pressure of brain and pulsation of the brain can cause further thinning of this bone and can result into the encephalocele. And this encephalocele comes out through the opening, and this is known as Sternberg's canal. Miller-Sternberg's described this defect, and it is known as Maximilian-Sternberg's canal, and it comes out through that. There is a prolapse of the encephalocele. Now, here you don't see that the pterygoid process is very well pneumatized, but a lot of time you have well pneumatized sphenoid. And this leak comes out from the sphenoid, and you have something known as a teapot sign positive. The moment patient bends, the CSF leaks. And why it is so? Because sphenoid has an ostium in the anterior phase, and like a kettle, there is an opening. So when you bend the kettle, the tea comes out, and that is why it is known as a teapot sign. Here is again a spontaneous leak which is coming from the right sphenoid. You can see the titubate image. The dye is coming brilliantly from the right side of the lateral wall of the sphenoid sinus. And on exposure, I've already dissected. What you are seeing is the anterior phase of sphenoid. Sphenoid is widened, and you can see that the lateral wall of the sphenoid is pulsating. We have progressed a lot. Initially, we used to obliterate the entire sphenoid sinus. Then we started doing only the pterygoid process. Now we do very precise leak closure. Here you are seeing that the encephalocele is reduced and surrounding mucosa is removed, because you don't want any mucosa remaining around that, and you see a nice circular opening. Now I'm telling you why I switched from fat to fascia. See, here I'm trying to put the fat. I really don't know where it is going. So when I want to put little more fat, I'm lost now, which is exact area. So I'm removing the fat, and you see that precisely I'm putting the strip of the fascia lata, and I can see under my vision, and I can slowly introduce that into the defect and close the active CSF leak. Once I've closed the active CSF leak, I spread the fascia onto it. And you see carefully, I'm using a lot of otology instrument here, because I get to see better, and instrument takes up very little space. And here you can see the tissue glue coming in. And again, you want to put a gel foam. You want to put plenty of gel foam, because you don't want your marrow cell to be in contact with the glue. Otherwise, your graft will come out when you remove the marrow cell. This is another case where there was an extensive pneumatization of the sphenoid lateral wall. And this clip is before the transpterygoid approach was introduced in India. We were one of the first group who went to Kassam's course and learned the transpterygoid approach. But this clip, you can see that there is a lateral extensive pneumatization. And not all patients requires transpterygoid approach. Here, this is 70-degree telescope being used to delineate the site of defect and the encephalocele. Reaching this space was almost doing acrobatics. Here you can see, and I've not edited it too much, because I want to see that when I use the upward bipolar, it was hardly reaching. Only very little area I was able to cauterize. But still we needed to cauterize the entire encephalocele. You can see only part of the encephalocele is cauterized. So we tried using the coablator. So we bend the coblator wand to reach that place. And you can see, I like coblator because you can have irrigation, suction, as well as coblation. So 3 in 1, so less instrumentation and better access, but I was not able to reach there. And this was way back 2008, before we went for training with Kasam for trans-tracheotomy approach. So again, you are not able to reach, and then ultimately I was able to reach the place using the frontal curette and frontal forceps. So you can see the giraffe forceps going there to remove the entire encephalocele. And now you can see the site of the defect. And with the same acrobatic, that repair was closed. You can see the double curve curette going there, and it is very well reaching in the area of the defect. And then you can see the pulsation and active CSF is closed, and further reinforce this leak using a piece of fascia. Once the fascia is placed, then the glue was put. When you want to do the trans-pterygoid approach, you need to drill the lateral recess. While drilling, sometimes you can come across the sphenopalatine bleed. In fact, always you come across the sphenopalatine bleed. So you need to close this. Here in this patient, you had multiple leak. You can see the seed-like opening in the bone. So we had to close that area in addition to closing the lateral sphenoid leak. Here you can see that in the lateral sphenoid, in the Sternberg's canal, the fascia is being introduced with a flag knife. We have a very nice publication of otology instrument in rhinology and microear instrument in nasal cavity. So what is very important is before you close the site of the leak, you must remove every bit of mucosa, because otherwise you will have mucocele coming up. This was our patient operated 15 years ago, where the lateral sphenoid lateral wall leak was closed, and this patient presented to our neurosurgeon with a huge mucocele. Initially, it was not identified as mucocele default. It was a space-occupying lesion, and MRI, it was brilliantly illuminated. And when I did a diagnostic endoscopy, this was the area. You can see in the lower down picture, endoscopic picture, that there was little pus area seen, and during diagnostic endoscopy only I was able to marsupialize this defect, and we enlarged that opening, removed that mucocele and drained it. So from the time we had this case, we are very, very meticulous about removing every bit of mucosa from the sphenoid prior to the repair. Coming to this interesting young boy, presented to us with intense headache and active CSF leak when he sat in front of me in the OPD. And he said, I have an intense headache. The moment we did the CT scan, we saw a large pneumocranium. And we saw something bony, and which was suspected as probably osteoma. But we were not very sure. This patient, so as we discussed earlier, presence of pneumocranium is an immediate indication for surgery, because otherwise the defect is so big, the air keeps going in, the patient can get frontal lobe signs. So this patient was taken up for emergency surgery. This is also one of the very, very old case. You can see the uncinatomy being done using a sickle knife. You can see that the moment uncinatomy is done properly, you can see the maxillary ostium. You remove the upper part, you twist clockwise in the left nasal cavity. And when you are doing the lower part, you do anti-clockwise and remove the uncinate process. Once the uncinate was removed, I started using the debrider to reach the site of the osteoma and the defect. So here you can see the debrider being used to clear the antioethmoid cells. And I was already able to palpate the osteoma through the you can see the osteoma being delineated and surrounding cells are removed. I'm using a curette to rock the osteoma from all around. Removal of the osteoma is very tricky thing, very simple. Just loosen it from all around. And gently you can deliver it. But when it is coming out, see carefully. There is one area of tentacle or projection from the osteoma which was responsible because it pierced in the dura. This is the projection which pierced the dura and resulted into the CSF leak and pneumocranium. Here you can see the osteoma coming out. And once the osteoma has come out, just see the site of the defect. Once you go inside, you can see the tear in the falx cerebri. Can you see where the air is coming from? Is the defect, and this defect itself was closed in the dura using a bath plug technique. So here you can see the bath plug going in. What I had done different in this patient, because this was a large defect, I needled my graft. I threaded my graft through the needle. I'm using a knot tire to spread my graft so that center of the defect and is the center of the repair. And my graft is properly placed, because sometimes once you place the graft, you don't know whether you are covering the entire area of the defect or not. So here the graft was placed all around. And once I was happy with the placement of the graft, I cut the thread of the bath plug. While putting this graft, you would be very meticulous. You should not put any crease. You should spread it very well and make sure that it is in touch with the bone. There is no dead space in between. And you can see the thread is being cut. And once it's spread, I'm putting the tissue glue and gel foam all around before I'm putting the piece of Merocell to give an additional tamponade. You always piece 2 pieces of gel foam. Sometime while doing optic nerve decompression in the patient with traumatic amaurosis, that is following a trauma, if there is a blindness, then we do optic nerve decompression. These patients have got multiple fractures. The moment you disturb this area, you can have a large CSF leak. So we always take a consent that while repairing the or while doing the optic nerve decompression, you can come across a CSF leak. Now you are already decompressed the optic nerve. You don't want too much of pressure onto it. So you put a tiny piece of soft tissue was put to close this defect, and hydrocot gel foam was put so that the optic nerve is not compressed. Coming to the series of cases of CSF autorhinorrhea, as I told you that when there is a intact impairing membrane, there are times when patient can present with a CSF leak. Now here you can see that the left side of the mastoid is very hazy and there is an abnormal cochlea. If you see the MRI, you can see the eustachian tube which is lettered bright white. So that is what we call as a eustachian tube sign. It is, I think all the icons are seen, so you're missing that picture. At least I can't see it. So in these patients, here it is coming from the foot plate. So when you clear that, CSF comes out. So what one can do is remove these stapes. Please note, all these patients have got a dead ear. So you can remove these stapes and close the oval window area. And put a tissue glue onto it. So these repair can be done endoscopically, endometrially, but transaortic repair you have to do. So same patient, here you can see the incus stapes, a small arachnoid prolapse, which suggests that there is a CSF leak coming from that. And on opening that area, you see a lot of CSF coming out. And you are seeing the IS joint being dislocated. And incus and stapes is being removed. Please note there is a defect in the footplate of the stapes, which was responsible for this CSF. And here you can see the soft tissue going into the oval window space, and CSF is closed. Sometimes you have a iatrogenic CSF leak. One should not be like an ostrich, but identify the site of the leak and close it. Why you get CSF leak during the endoscopic sinus surgery? Because you have a large frontal bone. Frontal bone is thick and which combines with the ethmoid, which is very, very thin. And this union is further weakened by anterior and posterior ethmoid artery, which traverses at the junction. So when you see this anatomy, this is the lateral lamella, which is very thin. It unites with the frontal bone, which is very thick, 10 times thicker than this bone. And these two reunion is further weakened by traversing vessel. So this becomes a weak spot. So whenever you are operating, and this is a medial lamella. So whenever you are operating, and if you face the lateral lamella, very easy to enter the cranial cavity and have a CSF leak. So whenever there's olfactory fossa Keros type 3, then there is more chance of getting a iatrogenic CSF leak. So whenever you're operating, don't follow the route of the turbinate, go laterally and operate to avoid this leak. And whenever you are doing anterior to posterior ethmoid, once you have finished posterior ethmoid, if you go in the same direction, you will enter the cranial cavity. So one needs to go inferiorly and medially to approach the sphenoid. So once you finish posterior ethmoid, go medially and inferiorly. However good you may be, there are cases where you will have failure. Failure occurs mainly if your graft and the defect area has got a dead space in between. So that's why again and again I said, you create a raw area, make sure your graft is in close connect with the bone, surrounding bone. So you can have, if there's a dead space, you can have failure. Or if you're operating a very large defect, you can have a failure. This was a child who was sent to us like this. Mouth gap, a huge encephalocele coming out of the nasal cavity, 30-day-old child. And absolutely unable to breathe, so they put a mouth gap. And this is what we did in the surgery. We had failure at first go. We had to revise this child because it was a very large defect. And in this defect, we had used Haddad flap. All of you know that the Haddad flap is, this is not working. Haddad flap is based on the sphenopalatine artery. Or you can have failure if you have multiple defects, you close one and the other opens up widely. This was the patient who had multiple defects. There were multiple fracture and multiple defects. We almost had to put 2 bath plugs to close this defect. So if it's a multiple defect and you have missed one, then you will have a failure. Or if you absolutely go and close the wrong site, you will have failure. This was a gentleman who underwent the surgery. Transcranial surgery was done by neurosurgeon and patient had immediate post-op leak. When we studied the scan, we realized that the leak was coming not from the frontal area. It was not an anterior fossa leak. It was coming from the roof of sphenoid. Now, whether it is a roof or a lateral wall of sphenoid, it's a blind spot for our neurosurgical colleagues, and it must be tackled endoscopically. This was another patient who presented to us with one of our colleagues had done a CSF Rhinorrhea closure. And actually the leak was coming from the ear. Here you can see the MRI, where you can see in the left side, the entire mastoid is filled up with the CSF. T2 image of MRI, CSF is lit bright white. And you can also see there is an abnormal cochlea. In the next cut, you can see it coming out from the eustachian tube. Now, by this time, I had already met Professor Levent Seneroglu, who has done a lot of work in abnormal cochlea. And he said that I shouldn't have removed the stapes, which I showed you earlier. Instead, what we should do is, whatever is a defect in the stapes footbed, we should further widen it and then close the repair. So in this patient, what we had done was, there was a lot of leak coming from the footplate. I used the skitter and drilled on the footplate and made that small opening into a wider opening. Immediately, you can see the CSF leak decreased. The pressure with which the CSF was coming decreased. I've kept the stapes intact and I'm closing this repair using Seneroglu's technique. And where he feels that the keeping stapes in place improves the tamponade, it keeps your repair in place. It further helps in the repair, and you can see the leak getting closed. And here tissue glue is being put, and this leak was closed by endomeatal approach. This is just an 18-month-old child, so we had to use a pediatric endoscope to do this repair. And also you have to keep in mind the possibility of the empty sella. So always study your scan, rule out the possibility of the empty sella, because if there is an empty sella, there is a possibility of spontaneous leak. And it is likely to be a high pressure leak. So I hope this presentation of mine gives you an overview of repairing the CSF leak endoscopically. And if you study the scans well, if you know the site of defect well, and if you do a meticulous surgery, you can just close the CSF leak with far less morbidity and mortality as compared to any of the neurosurgical approach. So thank you very much, Dr. Khaund. I'm there. I'm open for any questions if there are any.
There are a number of questions. Thank you, Dr. Hetal, for a very comprehensive presentation on CSF Rhinorrhea management. It was very enlightening. Your videos have been very informative, and also your experience with CSF Rhinorrhea presenting as rhinorrhea, that has been also be very nicely highlighted. I think before I sort of give too many comments, there are a lot of queries which I think you should be answering. So the first query has been there that for a 40-year-old female presenting with chronic headache, no frank CSF rhinorrhea symptoms, and MRI shows suspicious ethmoid fistula, fluid intensity in ethmoids. How should one proceed in such a scenario?
So in this patient, we have to, if there is no active CSF leak, what we need to do is you do a CT-PNS, which is high resolution. You should do a 1 millimeter cut and see the study, see the scans millimeter by millimeter, and ensure that whatever is the fluid, what is the Hounsfield unit of that, whether it matches with the CSF or not, or whether it is matches with the secretions. Second thing is that you can additionally do a MRI and see whether there is in T2 images of MRI, you see that fluid in the nasal cavity as CSF or not. And if there is any still further doubt, it's better to do a CT cysternography to rule out that it is not a CSF leak. But in these cases, sometimes the mucus in the nasal cavity also may present, and patient may have headache. It need not be a CSF leak. So one must keep all this possibility in mind, and unless you prove it, you should not operate. If you have facility of collecting the fluid and sending it for beta 2 transferrin also it helps. But in this patient, there is no active leak. So unless you prove that, you should not go in and operate.
Right. Thank you. The next question is, which imaging modality has better value for assessment, CT with cysternography or MRI cysternography in your experience?
No, no,
You
no,
touched
no.
on it actually.
See, CT cysternography is a gold standard. When you
Right.
can't do LP, when you can't put the dye, these are those patients where LP is difficult because patient is very obese, they are not getting the LP. Second is the patient is just recovering from meningitis, so you don't want to put a dye in the intrathecal system. And thirdly, if patient has a reaction to the dye, these are the only three scenarios where you can't do CT cysterno. Otherwise, CT
Right.
cysterno remains the gold standard. But if there is an obvious leak on the plain CT scan, and if I can just have ditto on the MRI, so 80% of the patient you can get just with plain CT and MRI, the site of the leak delineated. But whenever there is a doubt, CT cysterno has to be done.
And of course, if you do a CT MR cysternography, you'd still need a CT for your roadmap, isn't it?
No, no. So plain CT and plain MRI, T2-bed MRI is a must.
Yes.
So in our protocol, we always do a plain CT, we always
Right.
do a MRI, and when
Right.
we don't, when we are lost, we do CT cysterno also. Because
Okay.
MRI brain has to be done to rule out that there is no brain tumor, there is no empty cella syndrome, there is no high pressure leak, there is no associated pituitary tumor. So MRI is needed to rule out intracranial cause for CSF leak.
So before you call any CSF rhinorrhea, a spontaneous CSF rhinorrhea or whatever, your MRI brain is in your protocol. It has to be done always.
Yes, to rule out that there is no tumors.
Right. There's another query. Your indication for using cartilage for closure. In fact, you could expand it to how do you decide on which material you use for closure?
Yeah, if my defect is big, like those congenital defects, encephaloceles, I always will use cartilage. If there's a traumatic leak which is very large, the base is very large, because you can have a large encephalocele coming from a small defect. But if the defect per se is large, then I will use a cartilage. And all congenital cases, I always use a cartilage because you want that strong repair.
The next query is also it's a very common thought in everybody's mind. Is there a role for lumbar drain or VP shunt on a routine basis? Or do you have any specific indications for LP drain and shunt?
Not at all in a routine cases. There were way back in early 90s, we were doing lumbar punctures post-operatively for 3 or 4 days. We would do continuous lumbar puncture and keep the pressure to lower level. But nowadays we don't do it. But if I'm doing a very active leak like congenital CSF Rhinorrhea, one of the patient had to put a intrathecal drain because there was a third repair. Already twice the repair was done and it had failed, and the pressure was so much. And to identify the leak and to delineate the site of the leak and to keep the giving little time for a repair of the leak, the graft to take up, we had to do a CSF diversion, but it was for very temporary time, only for 5 days.
Right. There's one
Only
more
1%
query.
of the patient requires.
Right. So any specific reason for your preference of bipolar over coablator for reduction of meningoencephalocele?
Oh, bipolar is very fancy. Bipolar was all these years very good. Lately, in a very young child, I did a 15-month-old encephalocele. So bipolar would not open only there, and I use a not only coablator wand, I use a inferior turbinate coablator wand, tiny one,
Okay.
and it was so amazing. It was excellent to use that.
Even the coablator one is quite bulky because it won't go in the infant's
So I
nose.
use a turbinate wand.
Yeah.
Very precise. You have space for instrumentation. You are just fighting for space in a 15-month-old baby.
I think the next question is also a repeat of the previous one, CT cysternography versus MRI T2 images. You already cleared up.
Yeah, and also gadolinium MRI is not FDA approved, but a lot of places we are doing it. That is a off-label use of gadolinium for MRI.
Since we are talking about the diagnosis part, Is beta-2 transferrin a regular test for your protocol?
Not at all. If I'm
When
convinced,
do you, then where, in which cases?
so when you collect the fluid and it is very water clear, absolutely, and then you know it is a CSF, we can just send for chemical test, which is cheaper. While beta-2 transferrin is cost you 7 to 8,000 rupees, and it is not available everywhere. So we don't do it only in doubtful cases, like what you said, that there is some fluid coming, but we are not sure, we are not seeing the site of the defect, and the fluid is not very clear. Sometimes it looks turbid, but then you have to convince the patient, Baba, this is not CSF, send it for test and say that it's not CSF leak.
Right. The next question is about a pediatric case of CSF Rhinorrhea, operated twice. Transnasal approach, once on the right, later on the left side. Now has active CSF leak again. Should one consider transcranial approach or try with transnasal approach?
No, not in a
If defect
pediatric
is
case.
not very clearly identified on CT assessment.
Please extend the study to temporal bone. You will be surprised to see the leak coming from the temporal bone. So identify the site of the leak. However good you may be the surgeon, you may do a good meticulous surgery, but if you are plucking the wrong side, your surgery is going to fail.
Right. So the next question is about how long can we wait for post-traumatic, non-iatrogenic, or maybe non-RTL leaks for
Maximum
spontaneous healing?
2 weeks.
2 weeks.
We give conservative line of treatment, head-eye position with Diamox and everything. And when you do post-traumatic CSF leak, we always take, because you are disturbing all the fracture fragment.
Right. Which cases are better to get neurosurgery involved and advice for transcranial approach?
Very, very large defect. And if there is a associated intracranial mass, then better to involve. Like I had a patient with pituitary tumor at a CSF leak. I have to have neurosurgeon on board.
And what is your indication for using a vascularized flap?
None of the ENT leaks requires a vascularized flap unless it's a very, very large defect or you have done a skull-based tumors. If you have done pituitary, if you have done clivus, if you have done chordoma, if you have done meningioma, all of those defects will 100% require a vascularized flap, but not our routine cases.
Right. The next query is about what is your mantra for reducing failures? What should a surgeon ensure while repairing, doing a leak repair?
The most important is to master the art of reading the site of defect. So master the radiology, have your radiological friend, have lot of neurosurgeon friend, because they are the one who will refer to you.
Right.
And one of the other point of involving them on board is that their referrals come to you. Share the revenue, only then you will get referral.
That's true. And what is your post-operative care protocol? The nasal packing, how long do you keep it?
I keep for 5 days. And nowadays, when I do wellness pack, I don't have to remove the pack. So patient can go early home and they don't have to come back for the pack removal. But I basically keep the patient indoor for the IV antibiotics.
For how long? 48 hours or more?
3 to 5 days.
3
CSF
to 5.
patient remain 3 to 5 days in the ward. Because I want to do check dressing for the thigh also. Thigh stitches come out at 10th day. 10 to 13th day. Pack comes out on 5th day.
How should one approach?
And all that time we give them Diamox. 6 weeks Diamox post-operatively with potassium portchlor replacement because it's a potassium depleting diuretic. So we also tell the patient to take coconut water and banana and also report to us if they have tingling numbness. But we give them a morning dose of Diamox.
Right. So how should one approach a suspected case of bilateral cribriform leaks?
If there's a suspected case of bilateral cribriform leak, you give patient 2 different containers to collect the leak. Sometimes if there's a profuse leak, when they bent on that side, the right side leak will go to the left side. And also if it is a bilateral leak, I've had a patient where one side of the leak was coming from the cribriform, the other side leak was coming from the ear. It was again a patient with a road traffic accident. and there was a tegment defect on one side and cribriform leak on the other side. So study your scans very well. If you see a little bit of hazy mastoid, that means you know that there is something going on in the mastoid also. The first clue what you get is a haziness in the mastoid. And also
Is
the audiogram, you may be surprised to get the dead ear.
yeah. If it is a CSF Rhinorrhea, so it has to be. It is usually or always a dead ear.
Or you can also have a conductive hearing loss also. Mixed hearing loss. Like if there is a IP2, then there is a leak going on, but there is some hearing.
So is fibrin glue a must or an optional?
It's mainly for feeling good intraoperatively. There were many number of leaks which we did it in the olden days without glue. And blood itself is a good fibrinogen.
Right. The last query, I think, is about you put in the Fasalata as an underlay method, or you just plugged it. Probably this is the query
Onlay.
about the. No. I think this query is about where you did not use fat. You used the Fasalata for plugging the hole, the
Oh,
defect in the
that is one is
sphenoid.
going in the defect only. So it almost goes inside.
People want to know about the wellness pack. It is
A wellness
what is
pack,
that?
it is a new pack. Wellness is a trade name actually. VELNAZ. And that pack is like a sponge which can be put in the nasal cavity, and you don't have to remove. Uh, it is looking like Merocel, expanded Merocel. It is spongy, and you can use it for post endoscopic sinus surgery as well as post CSF leak closure, because you don't have to remove it; it dissolves on its own.
Is it something like the nasopore of
Yeah.
the Smith and Nephew company?
Yes.
Similar, I
Yes.
believe. Yeah.
Something like an nasopore.
There's one more query. Do you involve the neurosurgeon decision making in patients with IHT?
Of course. Intracranial hypertension, no? Increased ICT.
Yeah.
Actually,
This
when
from
there is a raised ICT, it is better not to do endoscopic repair. It is going to fail.
This is from Dr. Neelam Bed. In fact, the first question was also from Neelam Bed. She also have asked you, have you tried the Peter Wormhole bipolar forceps?
Yeah, Peter Bowman's bipolar forceps is very good, but sometimes the nasal cavity and in a pediatric age group, it's very difficult to open that. So
Sorry, I missed one question that she also put. Any role of conservative management if the patient is not willing for surgery?
No, there is no role of conservative management in a patient with an active CSF leak or a CSF leak which is stopped after CT cysternography. And if conservative role is only in post-traumatic case immediately. And if patient is not willing, there is no surgery which can be done when patient is not willing. But I write a written consent that patient has been explained the consequences of CSF leak. There can be possibility of meningitis, and patient is refused for surgery, signature.
There's one more query. I think that's the last question. How to differentiate CSF and secretions based on Hounsfield in CT?
Radiologist have there is a difference in the Hounsfield unit in CSF as well as on the mucus.
I would like to know from you, Dr. Hetal, that supposing you have seen a CSF rhinorrhea patient, spontaneous CSF rhinorrhea, you have seen a leak on the CT. When you take in the patient in the OT, you are unable to find the leak. So what are the steps do you do? It happens at times when you have explored and you don't find the exposed skull base, you don't find the leak at that point of time.
But you have identified the site of the leak on the scans?
On the scan. Yes, you have seen it on the scan.
I will go back to the scan, study the scan again. It has, ideally, it should not happen like that. There are people who say that, oh, there is, you can just put a carpet graft, do the full face, put the full carpet. I don't believe in that. Sir, if you identify it vigilantly and the scans are done properly, you will find the site of leak.
So actually, you can also do ask your anesthetist to do a Valsalva to increase the pressure.
So on table, once you're dissected, what you can do is tell your anesthetist to give you Valsalva, put the patient off the ventilator, do the manual, switch it to manual, give Valsalva, and then you can see. In fact, we do intra Valsalva once I've repaired also to see that there is no active leak.
Right.
Following my repair on table, I've got a good closure.
Right. I think we had an exhaustive discussion, and probably we have come to the 7:30. We have come to the end of our allotted time. I think
there
for
is
the
one more
benefit,
thing which one is described in the literature is use of fluorescein
right?
To identify the intraoperative leak. But fluorescein itself, it's a very good medium for Pseudomonas to grow. And secondly, it can give convulsions to the patients. So
Right.
I have never used fluorescein intraoperatively, but with blue filter, you can see the CSF very brilliantly. Says a lot of people who use the fluorescein.
I think after this talk, I can suggest a young IOHNS group to maybe create a flow chart for the benefit of others to how to go about in managing the CSF rhinorrhea cases. I mean, how you do not miss out on a CSF rhinorrhea presenting as rhinorrhea, or how you do not miss out on a high pressure leak. So if you have a sort of flow chart, you know that if you don't get this, you do this test, etc. So it will be beneficial for the young people.
Do you have a WhatsApp group of these people? I have a flowchart ready. I will share with them.
You can share it in the IHNS official group, maybe. That will be helpful for everybody.
Okay, okay.
Yes.
Thank you, Dr. Srinivas. I think we have come to the
Yes. I
end of the
request
time.
Dr. Nitika to handle the vote of thanks.
Respected faculty and colleagues, on behalf of the organizing team of the Young section of the Indian Academy, I extend my heartfelt thanks to everyone who joined today. A special and sincere thank you to Dr. Hetal ma'am for giving an excellent presentation and the practical surgical pearls which she has shared regarding the management. Thank you so much, ma'am. We are also grateful to our moderator today, Dr. Gautam Khaund sir, for expertly guiding the session. We hope that all the participants who watched today the webinar found it useful and would get benefit out of the clinical experience which ma'am shared. Please stay connected to our website for the next webinar details, and all those who have joined today late can watch the webinar on the YouTube. Thank you, everyone.
Thank you.
Thank
Thank you
you.
for an opportunity
Thank
to
you very
share the
much.
experience.
Thank you, ma'am. Thank you.
Bye.
Thank you, sir.
Thank you very much.
Bye-bye.
Please keep up the good work. Yeah.
Thank you.
Thank you, sir. Thank you, ma'am.